Good afternoon, everyone, and thank you for attending the third of the four-part lecture series on GI radiology. To formally begin this afternoon's program, let me first call a very dedicated member of the society who works tirelessly behind the scenes, and he has been a member of the Committee on Training Program for the second straight year, Dr. Alvin Velasco, to lead us into prayer. Dr. Velasco.
Thank you, Dr. Romano. Let us all put ourselves in the holy presence of God. In the name of the Father, the Son, and the Holy Spirit. Amen. Thank you, Lord, for giving us this opportunity to meet and learn from our speakers, even during these difficult times. Enlighten all of us that we may use this knowledge to further serve our patients better. Lord, we thank you for this day, for keeping us safe in this time of pandemic. Give strength to those who are weary. Restore health to those afflicted. Give hope to those who are in despair, and eternal rest to those who have departed. This we ask through Jesus Christ our Lord. Amen. In the name of the Father, Son, the Holy Spirit. Amen.
Okay, so for this afternoon, we are lucky to have very good speakers and very good moderators to discuss the imaging of the liver and the pancreaticobiliary system. What you see in your screens right now is an overview of what will transpire over the next 1 hour or so. So we will be having two lectures, two parts this afternoon. It will start with the normal anatomy and followed by the pathologic imaging of the diseases of the liver and the pancreaticobiliary system. And so for the house rules for this afternoon, everyone will be on mute while you are inside this meeting room and while the lecture is ongoing. It's always helpful to attend these conferences with two-way earphones or headsets with built-in microphones for clearer audio input and to reduce the unavoidable audio interference from your location. The lecture will be presented as a PowerPoint presentation, and it will be shared by a third party who will be able to control said presentation upon prompting. We encourage everyone to type in your questions using the Q&A and not the chat box so that the panelists will be able to field those questions and answer them during the Q&A portion after each lecture. Next slide. Okay, and let me take this opportunity to invite you to the last GI radiology topic, which will be this time again next Saturday. It will be on the esophagus and the stomach by Dr. Margaret Zaira Cabreros and Dr. Mark Joseph Sibal, and it will be moderated by Dr. Albert Ismael. And following this radiology series, we will also be having conferences on GI pathology for the next 2 Saturdays on July 25 and August 1. For the first Saturday, it will be on the esophagus, stomach, small and large bowel by Dr. Glenda Pua, and it will be moderated by Dr. Jose Soliano. And for the last of these 6-part webinar series, it will be on the pathology of liver and the pancreas. It will be given by Dr. Marife Bonifacio and moderated by Dr. Jade Hamias. Okay, so to formally welcome all of our attendees to this afternoon's forum, let me call on a very strong proponent of the use of technology in the delivery of these scientific activities, the hardworking president of the Philippine Society of Gastroenterology, Dr. Augusto Jose Galang, to give his welcome remarks. Dr. Galang.
Thank you very much, Dr. Robert Romano. Good afternoon to everyone and welcome to this virtual interdisciplinary conference. This scientific activity was conceived by the PSG Committee on Training Program as an adaptive response to the present COVID crisis to help, assist, and supplement the cognitive learning and development of our trainees using an alternative yet appropriate platform during these difficult times. In addition, this webinar also provides a venue for all members of the PSG to come together to revisit and review radiologic manifestations of certain digestive diseases. I would like to thank our speakers, Dr. Rudolf Kuhn and Dr. Annalyn Eggwolf, and of course, our moderators, Dr. Mark Anthony De Lusong and Dr. Janus Ong, for their valuable time and for agreeing to share their expertise to us. Again, thank you and welcome.
Thank you very much, Dr. Galang. So to move on to our program proper, let me first introduce the moderator. Our moderator for the first part of the lecture is one of the most prominent therapeutic pancreatico-biliary endoscopists in the country. He is a past president of the Philippine Society of Digestive Endoscopy. He is the head of the section of advanced endoscopy in the University of the Philippines, Philippine General Hospital. He's also the head of the unit in the National Kidney and Transplant Institute. He is a training officer, a past training officer in UPPGH, Division of Gastroenterology, and also an associate professor in the UP College of Medicine. It's an honor and a privilege to introduce Dr. Mark Anthony De Lusong. Dr. De Lusong.
Thank you very much, Shome, for that kind introduction. I'd like to thank the organizers for inviting me here. I'll be the moderator for the first speaker. It will be my honor and privilege to also introduce the speaker. So let me introduce the first speaker. Our first speaker is Dr. Rudolf Kuhn. He is a board-certified radiologist and founding member and current board member of the Philippine Society of Abdominal Radiology. He completed PET-CT, MRI fellowship, and radiology residency at the National Kidney and Transplant Institute, where he was chief fellow and chief resident and awarded as best resident of the year. He graduated from UST cum laude for both his Doctor of Medicine and BS Biology degrees. He published and presented researches locally and abroad, with his most recent study presented at last year's European Congress of Radiology in Vienna. He has garnered various grants from the Radiologic Society of North America and European Society of Radiology. He is a current peer reviewer for the Radiologic Society of North America case report collections, and he engages in social and civic work as founding member and executive secretary of Bayanihan MD, a nonprofit organization that organizes various medical missions and educational programs. So, ladies and gentlemen, please welcome Dr. Rudolf V. Kuhn. Dr. Kuhn.
Magandang hapon. Thank you very much, Dr. De Lusong, for that very humbling introduction. So, as mentioned, we are now in our third lecture series of 4, and this afternoon's topic is all about liver and biliary tree. So, allow me to start with a review of normal anatomy, and then Dr. Eggwolf will be presenting some pathologies involving the liver and the biliary tree. As I've mentioned last time, COVID-19 pandemic has changed the way we educate our residents and fellows, but it's through these webinars that we have found a new way to engage with our colleagues. And I'm very glad for the invitation from the Philippine Society of Gastroenterology. We have had good feedback about our last lectures, and I hope we can continue this. So for the outline of this afternoon's topic, I'll be again presenting using the multimodality imaging method. So namely, we'll be looking at ultrasound. That includes a little bit of shear wave elastography, computed tomography, MR resonance imaging, fluoroscopy, and finally I'll be presenting a short approach for diagnosis. Notice how I arranged the imaging modalities here. It's again arranged in their relative use of frequency. And last time we noticed that there was not much use for ultrasound in the imaging of the small and large bowel because of the presence of gas. But now ultrasound is has a larger importance in the imaging of the liver and biliary tree. And in many cases, it's actually even more sensitive in the detection of early cirrhotic changes or liver parenchymal disease and evaluation of stones in the biliary tree. Okay, so here's we call this a B-mode imaging of the normal right liver lobe. You will notice here the orientation of the probe. Let me just get my laser pointer. Okay, the probes also come with this marker here. And by convention, the marker is oriented cephalad of the patient. So that will be this part of the image. And that means that what's here on the left side of your screen is the cephalad portion of the patient. So this will help us orient ourselves as to the normal anatomy. That this hyperechoic structure, this linear or curvilinear hyperechoic structure, is actually the diaphragm. And we see here the hypoechoic structures that course through the normal liver parenchyma, and these are the blood vessels. And if you try to look at what the blood vessels are, you can actually differentiate them. The portal veins usually have this hyperechoic sort of halo around them. And the hepatic vein does not have such a halo. And of course, you will also find the right kidney. So if we look at the transverse image of the liver, you will have something like this. Again, to orient you, these are the hepatic veins. So as we said, the hepatic veins do not have this hyperechoic halo around them. And all of these, they will of course drain into the inferior vena cava. So similar image, similar orientation, now with Doppler imaging. So Doppler imaging will help us confirm that what we saw as a hypoechoic structure in the image a while ago was in fact a vascular structure. Okay, so I will discuss a little bit about liver segmentation in a while. But very important, of course, is the presence of these hepatic veins to help us delineate which is which segment. Okay. Let me see. Yeah, okay. So adequate preparation is important. We usually emphasize to our patients that they need around 4 to 6 hours of fasting in order for the gallbladder to be adequately distended. And when the gallbladder is adequately distended, the GB wall should measure less or equal to 3 millimeters. And here are also some normal diameters for the transverse and the length. And when we have, for example, a length of more than 10 cm, we can label it as gallbladder hydrops. Now, this should not be mistaken for pathology. These are normal valves, or rather folds of the gallbladder mucosal wall. So sometimes the mucosal fold can be so prominent that it already makes a separate compartment here at the one end of the gallbladder. So this is what we know as a Phrygian cup. So historical basis, this was actually the Phrygian cup during the French Revolution. And sometimes also a gallbladder stone can be hidden in the Phrygian cup so that it would not be so evident if you were just to focus on the body and neck of the gallbladder. Okay, I won't be talking much about shear wave elastography, but it is a novel method in ultrasound, and it allows us to have an idea of the hardness of a particular structure. So it becomes very useful for the detection and grading of fibrosis. So some institutions already offer elastography, namely shear wave elastography. And it comes up with a Metavir score unfortunately, the KPA, that are these numbers here, vary from manufacturer to manufacturer. Okay, so I'll be talking next about CT. So CT is, of course, a kind of cross-sectional imaging. And in many cases, we have seen that ultrasound is very useful for the detection of stones. However, especially in the region of the distal common bile duct, cross-sectional imaging is more useful because the presence of gas in the duodenum or even the stomach can obscure the presence of the stone. So cross-sectional imaging, where these structures are not superimposed on one another, and you can delineate each structure well, is very useful for that purpose. Now, the caveat with CT or computed tomography is, of course, that not all stones are visible on CT. So a number of stones in the biliary tree are actually radiolucent. Okay, so as a brief introduction, cross-sectional imaging using CT, of course, uses ionizing radiation. It is a kind of multiplanar imaging. So you can have multiple reformats into different planes, sagittal, coronal, and axial. And it allows dynamic evaluation with intravenous contrast. So we can make use of intravenous contrast, and we can have triphasic imaging. I'll be talking about that in a while. And also very important is that we can characterize structures by using Hounsfield units. Back now to multiplanary formats. If you were to look at the images here, it would be very difficult for you to delineate what is the cause of obstruction, or actually if there is obstruction. But if you see it now here in the coronal image, sagittal image. Now this is the axial and this is the coronal. The common bile duct here is dilated, and then up to this portion, which is not clearly delineated because of the overlying structures. So if you use intravenous contrast, it becomes a lot clearer, and you will notice that this is actually the common bile duct, and it's dilated up to this portion, and here's the pancreas. So here's a very ill-defined nodule at the region of the pancreatic head. So it becomes important to look at the different kinds of phases. We have the arterial, portovenous, and delayed or equilibrium. And we can characterize structures as to the Hounsfield units. So for example, if you were to see a stone here, you can characterize it by the use of the Hounsfield units. Now, as a short introduction to the Hounsfield units, they are a numeric value which allow the accurate quantification of the density of the structure. So pure water is around 0 or 0 to 20. We give it a certain leeway as to content. So if there's proteinaceous content, it can be a little denser. And then if it's fat containing, it's around -70, and so on. So on the other end of the spectrum, if it's calcified, such as a stone, it will have a high HU of 1000 plus. Okay, so if you were to look at this image, focus on the two arrows here. Even though you don't have always a measurement, so the way we measure it is actually with a region of interest. You can mark it on the workstation. But if you are not dealing with the workstation and you're just dealing with plates, a helpful method is to look at surrounding structures. So if you were to look at the subcutaneous fat of the abdomen here, so you would get an idea as to the appearance of fat. So you see that fat is also found in this lesion. So we can diagnose this as an hepatic lipoma. So that's the use of the HU, or the Hounsfield units. So I'll be talking a little also about segmental anatomy. This is the language of our surgeons and perhaps interventional radiologists. So it's quite useful to know on how they segment, or we segment, the liver. And this is, of course, the Kuhn classification of segmentation, as modified by Bismuth also. If you will notice, anatomically, of course, we divide the liver into right and left using the falciform ligament. However, from a functional viewpoint, we use Cantley's line, which is an imaginary line drawn from the IVC to the gallbladder fossa. So this would put segment 4, 2, and 3 as the left lobe, and 5, 6, 7, 8 on the right lobe. And behind it is, of course, segment 1, the caudate lobe. The falciform ligament, of course, can also be seen on CT, and will give you an idea, of course, where segment 2 and 3 are. Now, another point of demarcation is the presence of the portal vein. So whatever is above the portal vein, it can only be segment 2, 4A, 8, and 7. Whereas below the portal vein, that's on the next image, and also at the approximate plane of the kidney and the pancreas, it's only segment 3, 4B, 5, and 6. And as mentioned a while ago in the ultrasound image, to delineate between all of these segments, we use the plane of the hepatic veins. So if you look at this image, this is the middle hepatic vein. This will be your right hepatic vein. And this is the falciform ligament. Here's the gallbladder fossa. What you have between the falciform ligament and the gallbladder fossa will be your segment 4. Okay. So let's look at this image for practice purposes. Okay, we can scroll this image. And we will immediately see here the IVC. This is the right hepatic vein, middle hepatic vein, and the left hepatic vein. So this will form our basis of segmentation, as well as you scroll a little down, you will see here the portal vein, right and left portal vein. So of course, this is a portal venous face in order for you to delineate the vascular structures best. Don't be distracted by this renal tumor here. Okay. Sorry. Okay. Let's track back to triphasic imaging or multiphasic imaging. We have usually a non-enhanced CT as well as a arterial phase, which is around 35 seconds. And we have a portovenous phase, which is around 70 seconds. And we have a delayed phase or equilibrium phase, which is around 600 seconds. So there can be some variation in the timing, depending also on the speed of the CT machine you're dealing with. Okay, so just as a little review of how the contrast travels in the body, of course, it starts with intravenous contrast, but then it will switch, of course, to the arterial side. So we see lesions that are supplied by the hepatic artery in this phase. Then there will be maximum perfusion of end organs. There will be, of course, opacification of the portal system. So, of course, from the GI tract, we know that the venous drainage will be through the portal system. And then there will be further contrast now seen in the venous circulation. And finally, in the delayed phase, or a little later than that, we will see excretion to the genitourinary tract. So, of course, we know that the portal vein provides 70 to 80% of the blood flow to the liver. And that becomes very important when we try to look at the different kinds of pathologies that can affect the liver. So here in the arterial phase, this is the phase that we best see the hypervascular lesions such as hepatocellular carcinoma, focal nodular hyperplasia, or an adenoma. Metastasis is best seen in the portovenous phase, and cholangiocarcinoma, as well as the scar of FNH, and fibrolamellar carcinoma is seen in the delayed or equilibrium phase. Now, I don't want you to memorize this, but rather the basis for understanding this is to understand physiology and pathophysiology. So, of course, we will have a lecture in, I think, 2 weeks' time. It's about pathology. But we know that the HCCA, as a tumor, there is, so the important thing is actually to remember if normal hepatocytes are present. And if you look at hepatocellular carcinoma, there's of course no normal hepatocyte, but rather there are neoplastic cells. And these neoplastic cells have a lot of neovascularization. And there's a lot of demand for nutrients, so that the supply of HCCA will actually be through the hepatic artery. And that has, of course, implication for our imaging, because we best see HCCA in the arterial phase, as well as for the interventional procedures, as I'll show you in a while. So for FNH and adenoma, they also, even though they are composed of hepatocytes, these hepatocytes are abnormal. There's pleomorphism, and there's loss of the usual portovenous supply, but rather the hepatic artery will take over. And in fact, FNH is said to be related to some vascular malformation. And adenoma, similarly to FNH, will also appear best in the arterial phase because it will be mostly supplied by hepatic artery. Now, how about metastasis? So you will wonder, why will metastasis appear during the portovenous phase? Well, we'll have to remember that metastasis is actually, these metastasis we're referring to is mostly hematogenous. And of course, hematogenous, the hematogenous route, given that we said 70 to 80% of the blood supply is actually from the portal vein, it will arrive through the portal vein. And many of the metastasis is actually from the GI tract, so that the drainage of the GI tract, we know, is through the portal vein. So obviously it stands to reason that metastasis will appear best during the portovenous phase, with the exception of hypervascular metastasis. Now for cholangiocarcinoma, even though it's a tumor and there's neovascularization, there's a very, very prominent fibrous stroma. And this fibrous stroma is very late to enhance, and usually enhances during the delayed phase. Similarly, the scar of FNH as well as fibrolamellar carcinoma is also composed of fibrous tissue, which is also tough and very late to enhance, and which will retain the contrast. So that's the reason why it will appear during the delayed phase. So as you see, it's important to have an inkling of pathology and to give you an idea when to look for these lesions during which phase. So if you look at this image of the liver, this is actually cirrhotic changes. Now we see the nodular and irregular outlines of the liver, and we see this hypervascular structure that enhances during the arterial phase, and it has washout or hyperenhancement in the equilibrium phase. So these types of imaging characteristics will help us in labeling this as a hepatocellular carcinoma. So obviously the pathology will be discussed in a while ago by Dr. Eggwolf, but just to emphasize the importance of adequate timing in performing these types of imaging. So another type of imaging modification, I would like to call it, which we have at our institution here and also many other institutions, is liver volumetry. Okay, so this will help the surgeons specifically deciding on what type of segmentation or what type of hepatectomy to perform. So this is actually a gallbladder mass, but I want to just to illustrate to you that we can get accurate volumes for the left, for segments 2 and 3 rather, and for the rest of the right lobe. And we can also do this according to other segments. So this will become very important for the surgical approach. And it will also allow us to create these computer simulations where we can get accurate volumes and surgical margins for the tumor, and to see how much volume is left of the rest of the liver. Okay, so let me proceed to magnetic resonance imaging, or MRI. Now, in MRI, we deal with several kinds of sequences, and there's of course the T1 and the T2 and so many other types of sequences, and it becomes frankly a little confusing. But some mnemonics can be quite helpful. So there's the mnemonic World War II, and it simply means that what's white on T2 is water, no? Water, white, T2, okay? So that will also, the same will hold true for fluid in the GI tract and bile in the gallbladder in the biliary tree, okay? So this is T1. T1 hyper is hyper intense, so that means white or relatively white. Some structures, of course, is fat. So subcutaneous fat will appear as relatively hyper intense on the T1. So that's just a quick mnemonic for you to differentiate between the T1 and the T2. And the fact that water or fluid appears as T2 bright is very, very useful to us in biliary tract imaging, specifically in something that we know as MRCP. But before I proceed to MRCP, I would like you to take a look at liver-specific contrast agents. So this is also very useful. We know that MRI uses gadolinium agent, but specifically for the liver, we have this liver-specific or hepatobiliary contrast agent. So this type of contrast agent is very, very useful for the differentiation of FNH and adenoma. So as I mentioned a while ago, the presence of a normal hepatocyte is very important to help us understand which types of structures or lesions will enhance during this phase. So much so that focal nodular hyperplasia, because it still has a relatively normal hepatocyte, will have a certain cell transporter system which will allow for the uptake of this kind of contrast agent. Whereas adenoma will appear as hypointense, so there is no uptake of this specific type of contrast agent. So it's very useful for the differentiation of these two pathologies and evaluation also of hepatic metastasis. And so because, as I mentioned a while ago, this type of contrast agent, its uptake will actually indicate that there's a relatively normal hepatocyte present. Okay, I also mentioned that another name for this is actually hepatobiliary type of agent. So it's also very useful for looking at bile leaks, specifically in the post-liver transplant setting, because it will have excretion through the biliary route. And usually it is reserved for problem solving and surveillance of specific HCC types. Okay, now let's review a little of anatomy. And let me just get my laser pointer. This is a Netter image, and then we will review it here with our MRCP sequence. So the MRCP sequence is actually a highly T2 weighted. And because of that, everything that contains fluid, such as here, your stomach, will appear as hyperintense, okay? So this is actually your common bile duct, and it will correspond to this. And then I will just scroll forward. So this is actually your left hepatic duct, and this is your right hepatic duct. This is the gallbladder, and we will just scroll back a little to see where it communicates. So this is probably the cystic duct at this area. And if you follow this structure, this is the stomach. We see again the rugae here. And if you scroll forward, this is the common bile duct again. It comes a little anteriorly. And this is the C-loop, or the second part of the duodenum. Okay, so common bile duct, and right next to it, the C-loop of the duodenum. So just look for the hyperintense structures, and namely the stomach, the duodenum, and then the biliary tree, of course. So we move anteriorly now, and then I'm moving again posteriorly. So sometimes this is the benefit if you're using a workstation, you can scroll through all the slices and you can follow each of the structures. Okay, so this is posterior part of the body, and we will notice that, of course, now there's the kidneys in our view, and this is normal T2 appearance of the collecting system. Okay, and just scroll forward to my next slide. Okay, yeah, that's it. So the MRCP, we can also get thick slabs. So that means several of the slices are somehow merged together, and you can have this 3D appearance. So here's the, again, the left hepatic duct, the right hepatic duct, common hepatic duct, common bile duct, and this is the normal fluid in the duodenum and the small intestines, and here stomach. So you can turn this around a little to get a better view. So the structures are no longer superimposed. And again, here's our common bile duct. So look at the MRCP sequence, particularly the thick slabs. Okay, so what are the indications usually for MRCP? Of course, it's identification of congenital anomalies of the cystic and hepatic ducts. We can use it for better delineation of post-surgical anatomy and complications. Choledocholithiasis, if it's not well delineated on ultrasound, and we mentioned that specifically distal common bile duct stones are very, very tricky on ultrasound. And also for evaluation of pancreatic cystic lesions. So this will actually, there's a common question if you would need to use contrast agent for MRCP. So actually you don't need to use contrast agent for MRCP. But if you're considering a pancreatic tumor, so you can also use contrast imaging for you to have one-stop shop, and you can have a normal upper abdomen MRI together with the MRCP sequences. Okay, so as I mentioned, it's heavily T2 weighted. It actually does not use contrast if you just want to use if you just want to look at the biliary anatomy. And again, fasting of 4 to 6 hours is needed. Okay, just to show you some images, we will not be discussing this really, but we use also fluoroscopy, but usually from an interventional standpoint. So these are images taken during a TACE, transarterial chemoembolization. And nice to know that actually the lipidol agent, which we use during TACE, is actually very, shows a high grade avidity for hypervascular lesions. So sometimes we see lesions on the TACE, during the TACE, which were not evident during the CT. Okay, so just another sample. So this is a large tumor in the left lobe. Okay, so again, another modification of fluoroscopy. We don't see it that much nowadays, but I presume you will have a similar view during your endoscopies, such as seen in this T-tube cholangiogram. And we know, of course, that this is a fluoroscopic study performed in the setting of hepatobiliary disease. And as mentioned, it's usually superseded nowadays by MRCP and ERCP. But of course, in the setting of post-cholecystectomy and the possible retained stone, T-tube cholangiogram is still quite useful. Okay, so we have discussed the different types of multimodality imaging. We have looked at the strengths and weaknesses of each modality. And I try to emphasize what normal anatomy and physiology looks like. So it's important to know what the normal anatomy is, how these structures are perhaps displaced, and identify the anatomy, maybe get an HU, and try to localize, of course. Imaging clues are characterization by HU we mentioned, or by looking at the different types of sequences. T2, bright lesions are fluid. And enhancement pattern, we have looked at the different types of enhancement. And then finally, take a look at the bigger picture, and that usually includes also the clinical history. So for a cirrhotic patient, any hypervascular lesion should be ruled out to be an HCCA. Okay, thank you very much for your attention. That concludes my part of the lecture. And we can have a short Q&A before we proceed to the lecture of Dr. Eggwolf.
Thank you very much, Dr. Kuhn. That was very informative. I actually learned a lot myself. The floor is now open for your questions. We have 2 questions in the Q&A box. Let us start with the first question. So someone sent in a question. Not all centers would have gadolinium. Should a normal IV MRI contrast help diagnose HCC?
So even though you don't have a, so actually there we have CT imaging, which uses intravenous contrast. So that's iodinated contrast. Then we have MRI, which uses gadolinium contrast. Now this specific type of liver-specific agent. So even though you don't have this liver-specific type of contrast agent, the typical enhancement pattern should still be there. So that is arterial phase hyperenhancement and hypoenhancement or washout in the portovenous and delayed phases. So I think Dr. Eggwolf will elaborate on this in a while. So we actually have also this type of classification system, the LI-RADS. So I think she'll be tackling that.
Thank you very much. And connected to that question, there's a question that says, what is the difference with MRI with IV contrast and MRI with Primovist?
Okay. So I don't want to use actually brand names, but okay. Primovist is actually the that's the brand name for the liver-specific agent marketed here in the Philippines. So in other countries, I think it's known as Eovist. But yeah, those are some of the common brand names. So that's actually the liver-specific agent, whereas the normal, the usual contrast agent we use is gadolinium-based, and also these have specific brand names based on the type of molecular structure.
And another follow-up question is that, are there any contraindications for gadoxetate?
Okay, without going specific into this brand, generally we are wary of patients who have end-stage renal disease, and for those members of the audience who were able to follow the first lecture, we mentioned that there is nephrogenic systemic fibrosis. And however, it is important to note that this type of complication occurs only with significant incidence among patients who really have CKD4 or CKD5. So if it's just a little, if the creatinine clearance is just a little below the normal, then we don't see this type of complication. And intravenous contrast for CT iodinated contrast is actually more dangerous than these types of gadolinium-based agents.
Okay, thank you very much. A general question, I think there's a lot of questions about contrast and HCC. So one general question is, when do you recommend MRI over CT scan in the diagnosis of HCC?
Okay, that's a very good question, but I don't think it has a very clear answer. Usually MRI allows better characterization because we have better contrast of soft tissue structures. We have better delineation of the contrast. But in many cases, patients will first have an ultrasound, and in many cases also first CT, because it's a lot more readily available. It's a lot cheaper. So in many cases, we can already diagnose using CT. But unfortunately, tumors don't read textbooks, and many tumors will have a typical enhancement pattern. So in cases of problem solving, specifically for the indications I mentioned during the lecture, there's a clear advantage for MRI, and also MRI using liver-specific contrast agents. So if it's a little, if you try to differentiate between specific structures, if you have a patient who is non-cirrhotic, and there's a question whether if it's FNH or adenoma, and you don't want to send your patient to biopsy, maybe you can do an MRI with the liver-specific contrast agent.
Thank you very much. I think we'll have 2 more questions before we move on. A practical question by one of the viewers is, in terms of image resolution or slices, is there a minimum recommended number that is deemed acceptable by radiologists for reading CT scans? I think he's talking about liver tumors as well.
Okay, if we look at our references, they just say multi-slice imaging.
Yeah,
So there is not really a cutoff, and yeah, but I think usually most of our centers have at least 4 slices above. I see only 2 slice or 4 slice CT in the provinces, but in Metro Manila, I think most of the institutions have more than that. And as long as you have multi-slice CT, you should be able to characterize the lesions well. Maybe it comes with a caveat of looking at the size of the lesion. So if you have a very, very small lesion and you are just dealing with a 2-slice CT, it becomes very difficult.
Okay, for the last question, I think it's connected to those slices. Dr. Akloa asked if we see a lot of hepatic hemangiomas that sometimes triphasic CT scan misses, and then they are picked up by MRI. And would you comment on this? Is this true? And if it's true, why is it so?
Yeah, I think it's true. I see several reasons for this, and one reason is that we have a better soft tissue characterization. So even on the plain imaging, because even when we say plain imaging by MRI, it means that we have done a T1, T2, and all those other types of sequences. So these help us pick up small lesions, and among them hepatic hemangiomas. And we have also better contrast. The contrast when it washes in the MRI, there's a better contrast resolution other than soft tissue resolution. There's a better contrast resolution, so that we're able to pick up hemangiomas also better on MRI. Yeah.
So basically, if we're thinking of a hepatic hemangioma, it's better to do MRI than a CT scan. Is that what you're saying?
Yes. There's better sensitivity and specificity when you talk about MRI. And yeah.
Okay. Thank you very much, Dr. Kuhn. In the interest of time, I think I'm going to end there. Can you answer the questions when the second speaker is lecturing, so that all of their questions can be answered? They're all in the question and answer box. Thank you very much again for your time, for sharing your knowledge with us. And can I turn the mic to the next moderator, Dr. Janus Ong, or Dr. Ome?
Yeah. Yeah, this is turning out to be a very lively discussion. So without further ado, the moderator for the second part of the lecture is a world-class hepatologist and one of the smartest people I know. He is trained in, well, everywhere I would have wanted to train, from Cleveland Clinic to the NIH and to in Johns Hopkins. He is currently a clinical associate professor at the UP College of Medicine. He is a member of the editorial board of the World Journal of Hepatology. He's also the associate editor of the Philippine Journal of Gastroenterology and he is an honorary member, a very valuable member of the Philippine Society of Gastroenterology. It's a pleasure to introduce Dr. Janus Ong. Dr. Ong.
Good afternoon, everyone. I'd like to thank the PSG for the invitation to be a part of this conference. And I have the pleasure of introducing our second speaker, who will talk to us about abnormal CT scan findings or abdominal radiologic findings in GI diseases. Our second speaker is Dr. Annalyn Eggwolf, and she is a founding member and officer of the Philippine Society of Abdominal Radiology, an officer of the Philippine Society of Ultrasound in Medicine, and a fellow of the Diagnostic Breast Imaging Society of the Philippines, the Ultrasound Society of the Philippines, and the Philippine College of Radiology. Next, please. She's currently affiliated with St. Luke's Medical Center, both at Global City and Quezon City. At Global City, she's the training officer for the Ultrasound Fellowship Training Program and a member of the liver transplant team. At the Quezon City outfit of St. Luke's Medical Center, she's the member of the research committee, and she's also affiliated with, next slide please, the University of Santo Tomas, where she is a member of the Radiology Residency Training Council and a member of the research committee, as well as the ad hoc committee on e-learning. Ladies and gentlemen, let's please welcome Dr. Annalyn Eggwolf, who will talk to us about abdominal imaging in diseases.
So good afternoon. Thank you, Dr. Janus Ong, for the introduction. So I will be talking about the role of imaging in the diseases of the liver and biliary tree. And this is our learning objective for this afternoon's exercise. One, to review the uses of various imaging modalities in the common diseases of the liver and hepatobiliary tree, to learn their limitations and strengths, and lastly, to be familiar with the imaging findings of the common liver and biliary pathology. So as a very fast review, these are the major causes of liver diseases, all of which causes alteration in the hepatocellular lipid metabolism, which facilitates triglyceride accumulation or hastens the accumulation of triglycerides within hepatocytes, leading to steatosis. Steatosis can be easily diagnosed on the different imaging modality using ultrasound, CT scan, or MRI. Although steatosis is a reversible condition, 10 to 30% of the time they may progress to steatohepatitis when there is inflammation, cell death, and scarring. Steatohepatitis is very difficult to diagnose on imaging. However, in a long-standing steatohepatitis, this will eventually lead to scar tissue buildup and eventually fibrosis. And we know that fibrosis can lead to more tissue damage and eventually cirrhosis. And cirrhosis is a major factor in the development of hepatocellular carcinoma. So as I have mentioned, these three imaging modalities have very high sensitivities and specificities for detection of fatty liver, especially for moderate and severe steatosis. But they are very limited or unreliable for detecting mild fatty liver. So steatosis is actually defined as accumulation of triglyceride in at least 5% of hepatocytes. So normally the kidney is of the same echogenicity as that of the liver, and we suspect the presence of fatty liver when the degree of echogenicity of the liver is of the kidney is emphasized, as in this example. In mild fatty liver, I usually look for the presence of probable areas of focal fatty sparing at the usual locations, and these are in the pericholecystic regions, as well as in the periportal region and the anterior segment. And it is important to note that in this mild fatty liver, the intrahepatic veins are well delineated. So Rumock-defined moderate fatty liver, when there is obscuration or haziness of the border of the intrahepatic veins, with partial obscuration of the hemidiaphragm and some parts of the posterior segments of the liver. So severe fatty liver in ultrasound, you will see that most of the liver is obscured and partially your visualization of the hemidiaphragm is also obscured, and in most instances, you cannot even see it. So the importance of this can be illustrated. So fatty liver in CT scan can be detected when the liver is darker relative to your spleen, or when the difference in hounsfield unit is at least 10 hounsfield. And when the liver has hounsfield unit of less than 40. And on MRI, this can be detected when there is a signal drop on out of phase relative to the in phase. So for fatty liver, the screening modality of choice is ultrasound because of its widely wide availability and affordability. So because this is a spectrum of disease, they can coexist at the same time. Fibrosis can be easily detected using your shear wave elastogram or MRE with very high sensitivity and specificity. So in cirrhosis, especially in advanced disease, it is easily detectable in the various imaging modalities. However, the tricky is when there is early cirrhosis. This overlaps with the imaging features of fibrosis or even steatosis. And sometimes they can just present as hepatomegaly with slightly coarsened parenchyma. And as the fibrosis advances, the right hepatic lobe atrophies, and then there is compensatory hypertrophy of the left lobe. And as subsequent fibrosis occurs and more scarring, there will be contraction of the capsule producing the wavy nodular border. So as I have mentioned, cirrhosis is one of the major factors that contributes to hepatocellular carcinoma, and it is advocated that a screening or surveillance imaging is necessary to catch subclinical disease, and ultrasound is the imaging of choice for these purposes. So the goal of screening is to detect subclinical disease, while the surveillance, the goal is to detect incident lesions in between imaging. And the 6 months interval is based on the expected tumor growth rate. So the American College of Radiology endorses the use of the Liver Imaging Reporting and Data System, or LI-RADS. This is designed to improve communication, patient care, education, and research. And this is consistent with the existing clinical practice guidelines. So the American College of Radiology recommends the use of ultrasound LI-RADS So there are three categories: the ultrasound 1, which is negative, with a corresponding recommendation of repeat surveillance in 6 months. So these are for those lesions that are most likely benign, and there is no suspicion that it might be hepatocellular carcinoma. And for ultrasound 2, that is when we find a lesion in ultrasound that is solid but subthreshold in size, that is less than 1 centimeter, the recommendation is repeat surveillance ultrasound in 3 to 6 months, and it is considered as ultrasound LI-RADS positive when the lesion is more than 1 centimeter, and further characterization with the diagnostic imaging modalities such as CT scan or MRI is recommended. So because of the inherent weakness of ultrasound, the ACR ultrasound LI-RADS would like us to assess the visualization score. So A for no or minimal limitations, B for moderate limitations, and C for severe limitations. So as we can see here, the severe limitation is due to the severe fatty liver and also probably cirrhosis. So the importance of this can be emphasized in this example, wherein this 81-year-old male was sent to the ultrasound section for screening ultrasound. The patient has lung carcinoma and hepatitis B. So because of the severe limitation of ultrasound and with high clinical suspicion for hepatocellular carcinoma or other lesions in the liver, MRI was done, and true enough, it showed a large mass at segment 4 with typical enhancement of hepatocellular carcinoma. So this is the CT MR LI-RADS. It has a lot of categories. This is mainly used for patients with that are with high risk for developing hepatocellular carcinoma, and these are those patients with cirrhosis that is not caused by congenital biliary sclerosis, and usually indicated only for adults and patients with hepatitis B, or those patients with current or past HCC. So for LI-RADS and C, these are those lesions that cannot be categorized due to image degradation or emission, and TIV stands for tumor in vein. This is specific for malignancy, but might occur, but is not specific for hepatocellular carcinoma. While LI-RADS M are those lesions that have enhancement pattern specific for malignancy, but that are specific for malignancy, but is not specific for hepatocellular carcinoma. And when your suspicion that the lesion that we are seeing is hepatocellular carcinoma, we have these three categories: the LI-RADS 3, LI-RADS 4, and LI-RADS 5. So LI-RADS 5 is actually the definite HCC, that is with the usual or typical pattern of enhancement of HCC. So this is a nice table which shows us that in LI-RADS 5, this is very specific for hepatocellular carcinoma, that you can actually diagnose it accurately using the parameters that has been established. So for LI-RADS M, these are lesions that are have a very high sensitivity for malignancy, but it's not specific for hepatocellular carcinoma. So for each LI-RADS category, they have specific recommendations. So as you have seen here in LI-RADS 5, this is HCC confirmed and no more biopsy is needed. But for LI-RADS 4, LI-RADS and tumor in vein, biopsy might be needed for a definite diagnosis. So this is the table that we commonly use in the radiology department. We look for, these are the major feature that points to hepatocellular carcinoma. So the main feature is the non-rim arterial phase hyper-enhancement. The bigger the lesion is, the higher the specificity or the probability that it can be malignant. And when it is present together with the other major features, which are the enhancing capsule, non-peripheral washout, and threshold growth, the suspicion increases. So threshold growth is actually defined as the increase in size of the lesion of at least 50% in 6 months or less. So this is an example of a hepatocellular carcinoma. This was already shown earlier. So there is this typical hyper-enhancement on arterial phase with rapid washout on the late phase with capsule enhancement. So it is more than 2 centimeters. It is non-rim arterial phase hyper enhancing with capsule, enhancing capsule and rapid washout. So this is a LI-RADS 5 lesion, typical of hepatocellular carcinoma. So this is another example of a 64-year-old male with abnormal liver enzymes and icterus. The patient has hepatitis B. On screening ultrasound, a large heterogeneous, predominantly hyperechoic mass is detected. And a further characterization with imaging, diagnostic imaging modalities is recommended. So CT scan showed heterogeneous enhancement on both arterial and venous phase. This pattern of enhancement is typical of malignancy, but is not specific for hepatocellular carcinoma. So this is a LI-RADS M mass. So in follow-up MRI, as you can see here, there is non-peripheral hyper-enhancement on delayed arterial phase with washout on portal venous delayed phases. So this is a LI-RADS 5 mass with typical enhancement for hepatocellular carcinoma. So this is another example of a 63-year-old male known case of liver cirrhosis secondary to chronic So the patient was sent to the ultrasound section for a liver Doppler ultrasound. And in B mode, the liver is enlarged with multiple hepatic lesions of varying sizes and echogenicity. And in addition to that, there's finding of dilated portal veins filled with thrombus. On the subsequent MRI, this thrombus in the portal vein enhanced, which cemented the diagnosis of a tumor in vein. And the lesions in the liver, the enhancement is not typical of hepatocellular carcinoma. That is, there is arterial enhancement, but there was no washout on delayed phases. So this was signed out as a probable infiltrating hepatocellular carcinoma versus cholangiocarcinoma. So another differential for a mass in the liver is cholangiocarcinoma. This is the second most common malignant lesion in primary liver, malignant liver lesion in liver lesion. So it doesn't, as was discussed by Dr. Kuhn, it does not enhance in early arterial phase, but in the delayed phases because of this abundant fibrous stroma. And because of the fibrous stroma, there is contraction of the capsule. And this is the typical enhancement pattern of cholangiocarcinoma. So for metastasis, as was discussed also by Dr. Kuhn, the typical enhancement is seen in the delayed phases as rim enhancement. And on T2, they are usually hyper intense. So we have discussed the malignant liver lesions. Now we will go to the benign liver lesions. So the most common benign liver lesion is hemangioma. And on ultrasound, in the background of a normal liver, these lesions typically presents itself as hyperechoic nodules with through transmission. And on contrast imaging, the pattern of enhancement is usually matches that of the blood pool. So here in all phases. So in this example, there's this lesion here with peripheral nodular enhancement that matches the enhancement in the portal vein. So, and here, this matches the enhancement pattern of the hepatic vein. This is very typical of hemangioma. So for focal nodular hyperplasia, this is most common in young females. The typical enhancement pattern is homogeneous arterial enhancement with central scar. So for liver abscess, this is a benign lesion, but can cause morbidity and can cause mortality. And an ultrasound, ultrasound is usually primarily used for screening. So the findings are very non-specific, and you can see poorly demarcated lesions, and sometimes you can see gas bubbles, but these lesions needs further evaluation with the contrast enhanced imaging. So on contrast enhanced imaging modalities such as your CT scan and MRI, you can see this fluid-containing lesions in the liver with a typical enhancement of early enhancement of the inner ring and delayed enhancement of the edematous outer ring, which enhances together with the normal liver parenchyma, and that is the double target sign. The cluster sign is usually seen because these are multiple fluid-containing lesions that coalesce and form a single lesion. So in this T2 image, you can see there's multiple fluid-containing lesions that coalesce and form a single lesion. This is termed as the cluster sign. So we're done with the common liver pathology. We will proceed with the pathology of the biliary tree. And the first hint that there is a pathology in the hepatobiliary tree is when there is the presence of bile duct dilatation. So when there is no obstruction, think of congenital diseases such as your Caroli disease and your choledochal cyst. And when there is obstruction, the most common cause is obstructing stones. But sometimes obstruction can also be caused by either intrinsic compression from neoplasms or extrinsic compression from adjacent structures that might be inflamed, or there's also tumor growth. So for no obstruction, the most common, of course, is your choledochal cyst, and this is the type 1 Kudani choledochal cyst. And type 5 are those when there is cystic dilatation of the intrahepatic ducts. So this is an example of a choledochal cyst, Kudani type 1. A 2-year-old male came in due to vomiting and was referred to ultrasound section to rule out intussusception. So ultrasound showed a fluid-containing structure anterior to the portal vein with which compresses the gallbladder, and this structure is contiguous with the hepatobiliary tree, and this was confirmed also with the same findings on CT scan. And this patient was treated with a choledochal cyst resection. So this is another example of a 35-year-old female who were sent to the ultrasound section due to abdominal pain. So on screening ultrasound, the common bile duct is dilated down to the level of the pancreatic head. So further evaluation with MRCP showed involvement of the left intrahepatic duct, which is typical of your Kudani type 4A. So in this image here, you can see this is the PTBT. You can see the aggressive contrast into the duodenum, which meant that there is no obstruction. And this is just a choledochal cyst. So this patient underwent biliary exploration with cholangiogram and bile duct excision and hepaticoduodenostomy. So this is a bile duct dilatation that is segmental in distribution, and it is typically saccular, and you can see this central dot on ultrasound and even in CT scan. When you turn on your Doppler, this lights up because this is actually the portal vein. So now we are going to go to the obstructing bile duct diseases, the most common of which is stones. And the gold standard for this is MRCP. But ultrasound can also diagnose presence of obstruction, and is usually utilized to screen the presence or absence of biliary ductal dilatation. So this MRCP showed a gallbladder that is filled with stones, as well as the common bile duct with resultant upstream dilatation of the intrahepatic ducts. So Mainly ultrasound is used to rule in or rule out the presence of obstruction, as in this case of a 45-year-old female with right upper quadrant pain, and they were ruling out cholecystitis. But on ultrasound, we see this intrahepatic ductal dilatation down to the common bile duct at the level of the pancreatic head, where we see this hyperechoic structure that is with intense shadowing. On further evaluation with MRI, there is this enhancing lesion in the distal common bile duct. So this is an intrinsic cause of biliary obstruction. So obstruction can also be extrinsic. So as I have said, ultrasound is primarily used for screening for the presence or absence of biliary obstruction. As in this case, there is dilatation of the intrahepatic common bile duct with dilatation, and the common bile duct is noted to be dilated, and there is a finding of a large pancreatic mass, which also causes pancreatic duct dilatation. So additional imaging of further evaluation with contrast-enhanced CT scan showed involvement of the adjacent structures and encasement of vessels. So the contrast-enhanced imaging modalities is actually used for mainly to assess the involvement of these adjacent structures and for prognosis and staging. So on PTBD, PTBD was done to relieve the patient of symptom, and we can see that this lesion is really obstructing with no drainage of contrast into the duodenum. So this is another example of extrinsic compression or cause of your biliary ductal dilatation. So there is this ampullary or periampullary mass compressing on the common bile duct. So on hilar cholangiocarcinoma, the ultrasound is usually used, as I have said, to detect the presence or absence of obstruction. So in this case, ultrasound was able to detect the presence of intrahepatic ductal dilatation with soft tissue fullness in this region. And there is a significant cutoff of these dilated intrahepatic ducts. So the gold standard for diagnosing hilar cholangiocarcinoma is MRCP. And as you can see here, you can see shouldering and the involvement of the bilateral secondary biliary radical. So the cross-sectional imaging modality is mainly used to determine the whether the patient the lesion is resectable or unresectable, though true resectability is determined intraoperatively. So, but with the use of the cross-sectional imaging, somehow you can reduce the number of those patients who will undergo a major operation by already deducing which of these patients are candidate for a possible resection. So for those patients, for those lesions that are unresectable, these are These are when the main portal vein is occluded or encased, and there is involvement of the secondary biliary radicle. When there is atrophy of a liver lobe with contralateral portal vein or hepatic artery encasement, or atrophy of a liver lobe with contralateral secondary biliary radical involvement, or involvement of both hepatic arteries. And the cross-sectional imaging can also give us more information as to the nodal involvement and the presence of distant metastasis. So, in the gallbladder, the most common pathology is cholecystolithiasis, and this can be diagnosed in all imaging modalities, including your X-ray. So in X-ray, you can see it in its typical anterior location in the upper abdominal quadrant. And ultrasound, you can see it as shadowing or non-shadowing mobile echogenicities within the gallbladder lumen. And on MRI, you can see it in the background of the bile in T2, the bright bile on T2 phase, and T2 weighted imaging. But although CT scan can detect stones, there are hypoattenuating cholecystolithiasis that are not visible on CT scan. So for screening patients in the presence of, for the presence of cholecystolithiasis, ultrasound is the best imaging modality of choice. So for acute calculus cholecystitis, it can be diagnosed in the presence of an impacted stone in the either cystic duct or in the gallbladder neck, and which causes irritation of the gallbladder wall, causing diffuse gallbladder wall thickening and edema, and in some instances, pericholecystic fluid collection. The diffuse gallbladder wall thickening can be seen in both ultrasound, CT scan, and even MRI. But on MRI, you can see fat stranding, pericholecystic fat stranding, which may clinch the diagnosis. So this is my last slide. This is a case of a gallbladder adenocarcinoma. They usually present late because there is no specific early symptoms. So in this case, we can see a nodular enhancement of all layers of the wall of the gallbladder, and we can see that there is involvement of the adjacent structures, the presence of the lymph node at the paracaval para-aortic region, and the presence of metastasis in the liver. So the cross-sectional imaging modalities are best for prognostication and staging. So that concludes my talk.
Thank you very much, Dr. Eggwolf, for that excellent presentation. Before we proceed with your question and answer portion, let me call Dr. Diana Payawal for, I guess, a burning question. She has been raising her hand, and I apologize for not acknowledging her. Dr. Payawal, I think the question is for Dr. Kuhn still. Is Dr. Payawal still online? So if Dr. Payawal is not online, I guess I could hand off the mic now to Dr. Janus Ong for questions for both Dr. Kuhn and Dr. Eggwolf. Dr. Janus Ong.
Thank you, Kit. Thank you, Dr. Eggwolf, for your wonderful talk. There are many questions, but one of the questions that I think was asked several times was contrast and renal insufficiency. I know you've answered some of it online, but do you have cutoffs for CT-IV contrast and MRI contrast for EGFR? Is it 30? Is it 45? Is liver-specific contrast safer in patients with renal insufficiency? And of course, the last question was in relation to this, the use of metformin, should they be discontinued? Should you get a 48-hour creatinine after CT-IV contrast? Dr. Kuhn and Eggwolf?
Dr. Kuhn?
Yeah, okay. I think it varies per institution. So at the NKTI, we have a threshold of around, and actually also it varies per institution and then the specific society. So the European Society of Uroradiology is one typical guideline we follow, and then the ACR. So usually we see complications at around 45 GFR below. So that's the time we usually want a clinician to sign off to give us some clearance. And then for 30 and below, specifically, we ask for nephro referral so they could help us guide in the hydration and if other medications are needed. So as for the question on metformin, this was also her burning topic mentioned during the first lecture. There is new evidence that has come out recently, and that's already reflected in the most recent American College of Radiology guidelines, that there is no need to withhold metformin before the imaging. Rather, we withhold 48 hours after exposure to the contrast medium. And what's also important to note is that this is usually with GFR of 45 and below. So if a patient has a normal GFR, no need to withhold metformin. That's at least according to the latest guidelines.
Okay, thank you very much. Thank you very much. There's a question on cutoffs for duct dilatation for extrahepatic and intrahepatic ducts on the different modalities. Are there set cutoffs for these modalities for duct dilation?
The normal caliber of the extrahepatic common bile duct is usually 3 millimeters, but it depends. It is it can be called as a dilated extrahepatic common bile duct when the caliber of the common bile duct is more than 7 millimeters in AP diameter. So for intrahepatic common bile duct, there is no actually a cutoff because normally they cannot be seen on any imaging modality, but when they can be visualized, there is that is a sign that there might be some obstruction.
Oh, okay. So the 7 millimeter, is that for ultrasound or is that for CT as well as for MRI?
That is actually for ultrasound.
That's for ultrasound. Is it the same for the cross-sectional imaging modalities?
Dr. Kuhn, do you want to answer that?
Yeah, we follow almost a similar cut of 7 millimeters also for CT and MRI. Sometimes 6.
Okay.
So there's some variation also between the various textbooks.
And I guess it's also depends on the fact whether the patient has a gallbladder still or not. Because those without a gallbladder, I think you allow for a larger diameter CBD.
Janus?
Yes, ma'am. Yes, Doctora.
Usually, we also compare it to the portal vein as adjacent. The common bile duct, for example, should not be more than 50% of the adjacent portal vein. That's why you have to compare it. So normally, you do not see the intrahepatic ducts, particularly in CT scan. You don't see them.
Okay.
See them already that you have some degree of dilatation. You really already note it out in your report. So for sa post-op, usually the cutoff is about 1 centimeter if you have a post-op or post-cholecystectomy
Patient. Okay.
for CBD. Yes.
Okay. And then I know it was, thank you very much, Dr. Fragante. Thank you. For the question on, you know, as clinicians, we all have to go down to the radiology department and look at CT scans and MRIs, and we see a buccal, and we don't really know how to differentiate between an HCC, a cholangiocarcinoma, and a metastatic lesion. Is there maybe something very practical that you can share for us to you know, bear in mind when we look at lesions and say this looks like a cholangiocarcinoma or a metastatic lesion or an HCC?
For HCC, there are usually risk factors, and these are hepatitis B and with the presence of cirrhosis. The typical enhancement pattern for hepatocellular carcinoma is rapid non-rim enhancement on arterial phase and rapid washout with capsule enhancement. But cholangiocarcinoma, on the other hand, because of, as I have mentioned, fibrous component, the enhancement is usually delayed, and it is also late when it allows the contrast to go back to the blood pool. So that's a main difference in their contrast enhancement. And because, as I have mentioned, the cholangiocarcinoma is mostly fibrous, there is contraction of the capsule. And in metastasis, the common enhancement pattern is rim enhancement, and it is usually seen in the delayed phases.
Thank you. Kids?
Janus, yeah, can I cut you off? Because I think Dr. Payawal is actually raising her hand again.
Hi.
Can we call her?
Hi, thank you. Thank you very much, Mark. Congratulations to our two speakers. There are multiple questions I have. One is, we are setting up a system of contrast-enhanced ultrasound. And this is to actually access liver cancer that we do on local regional therapy and being short of doing MRI and CT scan. May I know your experience on contrast-enhanced ultrasound? Secondly, are you now trying to say that we can replace LI-RADS with MRIS, modified RISIs, that we use to assess response assessment criteria, RISIS, RECIST, short of the LI-RADS that you do? Are you now trying to say that this is supposed to be a better strategy than the modified RECIST strategy that we are doing? The third is we do local regional therapy with microwave and RFA. It's so difficult for us, for me personally, to assess or to get lesions in segment 4, A and B. May I know what technique or tip you can tell us on what position your patient would be if you want to get segment 4A and 4B? Thank you.
Could I answer the question about the contrast enhanced ultrasound, because I think the younger panelists did not have experience. We tried to use the contrast enhanced ultrasound. Unfortunately, what was the FDA approved contrast was only from Europe, and at other times from Japan. So there was no real FDA approved for the Philippines. So what we did before was only samples given to us. And the cost at that time was almost the same as that of a iodinated contrast, and so at the time it did not really break off. But we are actually very willing to do the contrast enhanced ultrasound, especially with the newer machines that we have. And particularly in NKTI, because we're very conscious about the usage of iodinated contrast, we are going to be pushing really for the contrast enhanced ultrasound. Now, under ma'am, we were talking about MRCP. MRCP actually is for solid tumors. Actually now for the liver, for particularly hepatocellular CA, we do have other criteria to use, because what we want to see is the enhancement of the remaining viable tissue, especially those post-stays, because we see the contrast enhancement, and that's actually what you measure rather than the actual size of the tumor.
Correct, Professor. What we wanted to know is how do you assess viability or remnants of a tumor we do for local ablation therapy? Because that is the one that is the interest we have in repeat MR or CT scan. And sometimes when we do repeat this test, that's why I was alluding to a contrast enhanced ultrasound, which will be safer and probably more cost effective for our patients. What do you think?
The difficulty, ma'am, for the contrast enhanced ultrasound is actually you do see the viable tissue, but the measurement is more difficult. So actually what we could also use for, instead of MRCP, is Choi criteria, which actually measures the remaining viable tumor. This is based actually on contrast enhancement rather than the tumor size itself, which is what is measured.
So ma'am, is it routine for your society to actually include the LI-RADS score and the MRCP score in your reading? Because sometimes we don't see them. Is that a recognized criteria that you as a society is using already? Because, you know, like in pathology, they use a certain criteria already.
Yes.
So maybe what I suggest is it standard? Because sometimes the reading is different from each institution.
Yes, we have been pushing for inclusion of LI-RADS classification. Although actually when I was talking to the hepatobiliary surgeons, if they would like to use LI-RADS, for them, yes, we could or we could not. But if your society would urge us to use it, we will be using it also for our readings. We will include LI-RADS.
I don't know if Janus would agree. We are urging you, ma'am.
Yes, I talked to Janus. We said that we will start LI-RADS classification in PGH and NKI.
Maraming trabaho, pero maganda siya.
Yeah, it's easier for those who are actually assessing. Also for general practitioners, sometimes they don't refer all patients to hepatologists or even to gastroenterologists. So at least from the general practitioner who does routine screening of these patients, probably it would be wise to include it so that they can actually know when to do therapeutic intervention. Ma'am, can I ask, this is a tip that I'd like to ask. When we do local regional therapy for segment 4A and 4-5, it's so difficult for me. Do you suggest any position that is that for us to be able to see segment 4A and 4B?
Ma'am, in terms of, actually, you have to do it ultrasound guided, and you use a substernal approach. You have
do you do it in a high sitting?
Yes, ma'am.
Okay, thank you.
The patient may be supine, but what the trajectory of your probe should be in the substernal area, turning cephalad. Or on the other hand, you could also put your probe on top, at the side of the sternum, and then your needle approaches substernally.
Okay, thank you, ma'am.
Habitus ng patient.
Okay,
So definitely before you do the procedure, you have to map out, do a preliminary ultrasound to be able to visualize the lesion so that you will know your approach.
Thank you, ma'am. Thank you, Janus. Thank you, Mark.
Thank you. Thank you. Do we have time for another question? I mean, there's just a question on TB, hepatic tuberculosis. Any clues on imaging that tells us that what we're seeing is hepatic tuberculosis from the speakers? From anyone?
hepatic tuberculosis, usually we see the when there is already calcifications. So they will present calcifications in the liver parenchyma. Yeah, so it's very non-specific.
And then what else? What is the difference between cholesterolosis and GB polyps and stones on ultrasound? Or can you with confidence actually say that what you're seeing is a polyp or cholesterolosis? I think that has some bearing for us when we're seeing seafarers. You know, they're sent to us for anything that's seen within the lumen of the gallbladder. So maybe, I guess that's a question from Dr. De Guzman.
Okay, gallbladder cholesterolosis, so on ultrasound, they may, it is actually very hard to differentiate between the two. On ultrasound, and except in instances where you can see a V-shaped reverberation artifact, that's when you can definitely say that this is cholesterol. But otherwise, it's a bit tough to differentiate between this. And for stones, when you do maneuvers, you can actually see that this will move on the maneuvers that you're doing, whereas your polyps, this will stay where it is.
Thank you. I think that's why sometimes you have a reading of polyp, and then the next time there's no more polyp seen, maybe because it was cholesterolosis. So I think we have come to the end of our session. It was a very lively discussion. Thank you very much again to our speakers, Drs. Eggwolf and Dr. Kuhn, and also Dr. Fragante. Dr. Ome?
Yeah, indeed, it was a very lively discussion, and we have our speakers and moderators to thank for that. We are actually running late. We have gone beyond our time, so this will be given to you on Monday. You have the whole day to answer it. Please allot 30 minutes of your time to answer the questions. It will still be given via Google Forms. And again, if you enjoyed this afternoon's and this early evening's webinar, there is another GI radiology webinar on next week. And just a reminder also for all the attendees, before you leave or after you click on the leave button in the Zoom app right now, there will be a survey. Please answer the survey so that we can evaluate the CME activity. Again, thank you everyone, and thank you to our panelists for a very good scientific discussion this early evening. Thank you everyone, and good night.